Welcome back to Killer Cure. I'm here today with Bill Liao, and as always, you know he's walking somewhere. We're going to keep him going in that direction, and we often focus on prevention, early detection, and building healthcare systems that meet patients where they are. Today's guest is one of my favorites. She meets patients where they are, actually making sure that when they get discharged from the hospital, they get care that they need, and they move really in the direction of outside the four walls of the hospital and how we really give care into the home. So there's going to be a lot of great insight and topics on how to get care, access to it. And, first thing, wanted to just have Jackleen introduce herself. Jackleen, would you take a second and give us a little bit of your background and kind of a little bit of your journey?
Yeah, thanks, Todd. I'm happy to be here. I'm Jackleen. I'm a physical therapist by trade, and I'm from New Jersey originally. I went to Rutgers and New Jersey Institute of Tech, got my doctorate in PT, and we really started Resilient Healthcare pre-pandemic. And the idea was there is so much back and forth with hospitals and patients, especially patients that are sick enough to be in the hospital, but probably stable enough to receive care at home. And we saw it with my dad, and so that was really the beginning of this journey. Was my dad, before he passed for 4 or 5 years, was spending time between every setting of care. It was a huge burden on our family. And I live in Texas now, and I was traveling back and forth between Texas and New Jersey just trying to help manage his care. And so we realized there is a gap in care for a lot of those patients, and it doesn't affect just the patient. It affects the patient, their families, the physicians that are trying to manage and coordinate care. And so that was really the beginning of Resilient. And we, through the pandemic, we launched acute care hospital at home programs in North Texas. Since then, we've gotten really specific about where our core competency lies, which verticals we want to extend out of hospitals as partnerships with hospitals, and that's really where we live. So we're a tech-enabled MSO, and hospitals hire us as an MSO to manage programs that we co-create with the hospital on behalf of the hospital to expand services into the home. So acute care at home is one. Our largest vertical is actually physical therapy at home, and then we have some rural health initiatives as well.
Amazing. Can we dig in just a little bit more on your background? I mean, super educated, right? About the systems and processes and getting to that point and understanding like what was broken and how you could solve some of the problems of it is something maybe we want to get to the root cause of. Again, we met now, was it almost 3 years ago, 2.5, 3 years ago, and your model was really trying to drive towards some of the changes that were happening in the US. And now you've really, it's kind of transformed and you're, the PT at home world and how you enable the patients to get the access to care. But I'd go back to like what got you besides I mean, it's really, caring for your dad and doing all that. What really got you seeing the brokenness of the system?
And if you
Yeah,
can, while you're describing it, please unpack the TLAs, the three-letter acronyms for those in the audience that don't know what an MSO is, don't know what PT is. Yeah.
okay. Sorry. MSO
No,
is a
don't
managed
apologize.
service organization. So a management service organization. So we are the management company that the hospitals hire to stand up these programs and then to manage them, operate them, staff them, provide the technology, all of that. PT is physical therapy. But yeah, I mean, healthcare is fairly fragmented. Everybody knows that. And it is complex and confusing. And it's an industry that typically you don't know what you're going to get paid or when you're going to get paid if you're the one billing for the care provided. And so there's so many different stakeholders. There is the provider, and then the provider, there's levels. There's the health system, there's the hospital, there's the administrators, there's the actual doctor or physical therapist or nurse who's seeing the patient. So there's all of that in the provider bucket. And then there's the payers. And the payers are also it's government payers, it's commercial insurances. It's commercial insurances that have government policies. It's cash payers. It's corporate funded payers. And so it's an entire different bucket as well. And then there is the patient. And then there's the family that supports that patient. And so for you to build something in healthcare and have it successful, sometimes it's only one bucket that you're focused on, and it's not always the patient. And so when we built Resilient, the first question was, why are hospitals not extending care into the home or the community or meeting patients where they are today? Is it because there is no reimbursement path for them? Are they not going to get paid for this? And it's a little bit harder to sell cost savings or future cost savings than it is to sell a revenue generation. So when you walk into a hospital and you say, you should go and treat patients in the community because it's going to reduce your readmission rate, and then you'll be penalized less for readmission issues. But now you're selling them essentially something you can't exactly metric, because then they'll say, well, my readmission rate might have went down for some other reason. And so the first question was, if we're going to try to fill this gap, let's follow the money and let's figure out, is there a way that hospitals can actually be reimbursed for care that they deliver in the home? And then if so, how? And initially, I mean, pre-pandemic, there was no acute care at home program. Medicare was not reimbursing hospitals to provide care in the home. And then we forgot there's also regulations in healthcare. So even if Medicare says, yes, we will pay you to treat an acute care patient at home, and we will pay you a DRG, which means a bundled payment for that diagnosis, to be treating them, you have to make sure that you're allowed to legally in your state provide acute care in the home. And so when we stood up Hospital at Home during the pandemic, we did it with HCA's North Texas division. That was our flagship, and that was actually the first acute care program in the state of Texas. And during the pandemic, we went through workflows and we got Medicare to approve that they would pay for it. And yes, patient can go into the emergency room. They should be admitted instead of putting them in the hallway at the time because of how busy hospitals were in the pandemic. We can transfer them home and we'll treat them at home and we'll provide all of that care for them in the home. The state of Texas has to actually allow hospitals to extend their license as an acute care hospital into patients' homes. And so at that point, we worked with Governor Abbott's office to create a waiver for hospitals to allow them to extend their license into the home. So there's just so many different pieces in healthcare that you have to get right for you to even see a patient. Now you can see patients, and now are the outcomes good? Are we delivering an efficient manner? Are we optimizing care? Are we actually making it easier for patients and families? And so we did a lot of the acute care work initially, and then from there, we figured, okay, there's going to be different gaps in different life cycles of a patient's illness. And why don't we focus on outpatient care in the home? And that really teeters in, yes, post-surgical, but also preventative. And so if we can capture that outpatient bubble in patients' homes as an extension of health systems, then we can better manage the full cycle of care for patients. And I don't know if that even answered your question. I went on a rant, but
We like the rant.
there's just so many different stakeholders that you have to make happy to make this work.
So you're basically saying it's a little harder than Uber Eats.
Uber Eats, you know exactly how much you're going to pay for a pizza.
Yeah.
And the price of the pizza doesn't change depending on who's eating it.
And you don't have to certify the driver as has a license from Pizza Hut to deliver a pizza to a table.
Correct.
You know what you're going to get
Exactly.
paid. That's key. That screams something that I guess goes back to the question a little bit. Why would anybody in their right mind get involved in healthcare in the first place, right? Like all the regulatory hurdles, all the challenges, all that. And I'm a glutton for punishment. I've done it myself for 34 years, right? You decided to go full steam ahead, even though you saw the challenges of the payers are different. And take the US and the world, because Bill's obviously in Ireland and the rest of the world, it's just a different payer wrapper, right? And in each state, we have a different payer wrapper. And you were talking about Texas, right? There's 50 of those states and looking at 50 different wrappers and all of that. It's like, why would we all be so determined to do something in this area? And what drove you to do that? That's like, it's actually, I know why mine. Everybody has a why. I don't know, maybe Bill can share his too, but.
Well, the answer I've always given in the why is, well, my dad got sick and we watched that whole story and wanted to fix the gap. But that's my why in building Resilient. You're asking, why did I get in healthcare at all? It's a bait and switch, Todd. It is. I was an athlete. I was pretty good at school, and I said, I think I want to be a physical therapist because I want to work with athletes, in which I did when I first got out of school. That I worked in an outpatient setting. I worked with athletes. I worked with a lot of runners. And but in school, they don't tell you. By the way, you can get a license to treat. You pass your boards. Now you're a licensed physical therapist. They don't tell you that that doesn't mean you're going to get paid for the work. They don't. And I think that there is a gap in education. That's a whole other podcast. But
We could do that one too. We'll bring you back on for that.
clinicians do not know the way that money moves in healthcare. And I think I have been pushing that since I first graduated, started a private practice, and tried to navigate it. I mean, I remember I had my first private practice, I had an insurance contract with a big payer that was a fourth, maybe reimbursement than what the guy next door was making on his payer contract for the same exact patient, for the same exact treatment. And I wrote an email as a very naive 20-something-year-old new grad private owner physical therapist to the insurance company. I wrote a nice little letter, thought it was being really stern. Hey, my neighbor, he makes 4 times what I'm making on the same exact treatment. That's not fair. I want my contract to be more. And they said, that's not how it works. You need to have leverage when you negotiate with us. And I was just like, I was, because, you get out of school and you're like, well, you do the treatment, you get paid for the treatment. Everyone's probably going to get paid a little bit different, not 4 times different, but maybe a few dollars different. No, pizza would cost me $3. I have to pay $3 for the pizza, but Todd gets it for $1. It's crazy. Anyways, so I always loved the healthcare industry. I was always drawn towards treatment, fitness, wellness, health. I was an athlete. I played soccer, and so I've always loved the healthcare industry. But I've also always loved the challenge. So when that happened, I was like, okay, I think there's got to be a way that we create something that plays within these rules, but you have to know the rules to play within them, but you also have to know them to bend them. So that became a challenge for me. And here I am building an MSO, a healthcare company that works with hospitals, physicians, and payers. And I believe everybody wins in how we've structured this, but it is, this has been over a decade since of just it pivoting and reiterating and figuring out a model that works and can scale in America and globally, although that's a whole nother piece of how healthcare gets paid in different countries.
Bill, one thing you should know about Jackleen and our audience should know, she is probably one of the most committed founders I know. She's, and you can hear it, so much so, she's committed to her kids, her life, and her balance. And she yells at me like she's yelling at a kid coaching soccer while we're having like a board call, like all of a sudden, or something that's really meaningful for whatever. And then she's like, oh, yeah. And comes right back to the conversation. It's really amazing commitment.
Sad.
And you have to do that to simplify things in healthcare.
That's one thing I as a slight side quest, about 30% of my portfolio companies are female founded. And I've watched several of them, have families, have kids while staying CEO, while working in a high performance environment. And it's led me to the conclusion that actually being a startup CEO is potentially one of the most family friendly for a professional woman, because you do get to break some norms and have that call at the soccer match. And, one of my founders, Miranda Wong, who runs Novaloop, is just about to have her 3rd child, and the company's thriving. And she's just a genius at structuring everything. And I wonder if you are finding the work life or the life work balance to be better because you're a entrepreneur.
Probably so. So busy, you have to make it work. I have 5 kids, and one of them is a little baby. She's going to be 1 in a few weeks. So, yeah. And then, startup CEO, mom or not, it's a lot of work, and you don't work 9 to 5. You're working every day, all the time. Phone calls at any time, and so, yeah, you just make it work.
Well, you have the power to make it work as CEO, really. Like if you were working for someone else, you might not have the ability to make it work because you wouldn't have the priority setting ability that you do.
Although, if you work for someone else and you're a 9 to 5, you get to turn it off at 5. See, especially as a startup and a founder, you don't get to turn it off at 5. And so there's probably an argument you can make both ways.
Sure. I would add, though, that if you look at career progression for women in many countries where their average income rate after childbirth decreases significantly, that's not the same for successful, CEOs of startups.
That's an interesting study. I actually have no clue if moms as CEOs make more after they have their kids. But I mean, we have more bills after we have kids, so
Maybe even the mom part is a preparatory component for a startup CEO. Like you think about it, you got to juggle a lot, and
Well,
yeah.
my last pregnancy, she's going to be 1 in a few weeks. So I think majority of my board and it's a lot of this now, right? It's a lot of Zoom meetings. It's not really in person. Majority of people I was contracting with and my board did not know I was pregnant till I had the baby. And I sent a message when I had the baby. And so there is still a little bit of discomfort as a CEO, female CEO, when you are expecting that you are not sure how people will take it. Investors, is she not going to be able to run the company? Is she going to be distracted? Is the company going to hurt while she has the baby? And so rather than having these conversations, I just didn't tell them till I had the baby and said, oh, by the way,
Yeah,
I had the baby.
I
She's
think
super healthy and we're still gunning.
I think you should definitely have those conversations with the public now, because there's a perception shift that could be very useful. Because, like, you are my current record holder with 5 kids. That
Yeah.
actually platforms you.
Awesome.
Yeah, I only carried 3 of them. Only 3 came out of me is usually what I say. But I have 2 stepsons, and then I
I'm
have
sorry, that's
3
not even a
grandchildren.
distinction, right? Like, kids are
Nah, I
kids.
mean for me, we have 5 kids. Yeah,
Yeah, exactly.
from the age of 1 to 12.
Yeah. As I
Yeah.
said, you are my current record holder. You are platformed.
That's awesome.
I actually believe there are a lot of women out there who want to have a family and who also want to be entrepreneurs, and they think it's an either or. And I actually believe that it's not. It's a yes and. And yes, it's going to be
Yeah.
super hard. Like, it's super hard. Parenting is super hard. Entrepreneurship is super hard. Super hard is super hard. If you've got the passion, which you clearly do, you're up for that, right?
You know what's harder? Stay at home mom. There's no way. To
Yeah,
me, it is so much harder.
Yep. And
absolutely.
well, just to bring it back just a little, it is relevant because as an investor in startups and doing all that, you have to look at all aspects, and this is a testimony to what you've done and been able to accomplish. In our journey together, right? I was with you a little bit when you were going through some of the pivots and the challenges from COVID to the hospital at home to kind of where things are with resilient. I guess the thing that I hear from you is you try to make every aspect a win for everyone in the healthcare ecosystem, right? So you get centered around the patient. Do you think that the patient is where things are centered today? Was it centered there ever in the in my 34-year career, I'm not sure it has been. Patient-centered care is a buzzword, but I'm curious of where you think we are on the curve now, from one point to another.
Okay, so historically, no, I don't think it was ever centered around the patient. And I think that healthcare had an out. It was confusing. Patients didn't really understand. And before, like now, patient responsibility is so high. Their copays are high, deductibles are high. The bill that the patient gets is high comparative to 20 years ago, 30 years ago. And so also 30 years ago, you couldn't go on Google and ask questions. Guess what? 5 years ago, you couldn't go on ChatGPT and ask questions. And so now patients are empowered with knowledge and they can challenge the system because at their fingertips, if you have a cell phone or a computer, that's all you need for you to ask a question, get an answer in a way that you understand it, and then challenge the system. And so I think healthcare is being forced to become more patient-centered, which is amazing to see because it should have been patient-centered from the very beginning. And yes, sometimes you will get patients who, they're on WebMD and now ChatGPT and they're challenging things that probably shouldn't be challenged. But it is very empowering for both patients and their families to be able to understand healthcare, understand the EOBs that they're getting. They can feed that in an AI and they can understand.
Bill's going to pick on you for the
Well,
EOB. Yeah. EOBs
explanation
aren't
of
what happened in
benefits.
Ireland.
Yeah, sorry. Explanation of benefits. So when your provider sends a bill to the insurance company, the insurance pays their portion, and then the patient gets this. It's supposed to be an explanation of benefits. It isn't. It's like the patients don't understand half of it. It's like, here is what we were billed. Here's the payment. Here's the patient responsibility. Here's a write-off, or here is the cap. They don't, So now you can just put that letter right in ChatGPT or Google as AI, and it'll explain to the patient exactly what got paid, what they're responsible for, and they can ask for itemized invoices. And I know Texas had this law a couple of years ago. I think it's across the country now, but there's transparency laws now. And so hospital systems, health systems, they have to be transparent about what their prices are. Granted, I would love to see some transparency laws implemented on the insurance side, but because I think that would actually move the needle a lot faster than having hospitals put their prices up. But I think it is becoming more patient and family centered because they have access to being knowledgeable.
Once one insurer realizes they can do better business by being more transparent, that dam will break.
You would think, but in America, insurance companies are allowed to be publicly traded, in which case you have higher profit margins if you spend less money, and you spend less money on providing less care. So maybe
misaligned incentives arrive again, right?
Yeah,
go ahead.
I'm not a total free market wonk, and I do see companies, like we've seen it in banking, right? There's a lot of retail banking opportunities now that just fundamentally do a better job than an old retail bank. And they are more transparent and they are a bit clearer, and they're just winning market share by being just better at their job. And so I suspect that will eventually hit insurance.
Well, I think you have to follow the money on both sides, right? Insurance is getting paid through corporate America. So if a corporation is using that insurance for their employees, then that's how they get paid. Granted, they also have government contracts, etc. But if corporations require insurances to become more transparent, then corporations might switch who they use. Narrow networks are starting to appear a lot more now, which I'm very for. Self-funded corporations are starting to think of, where can I contract with a narrow network rather than just these huge third-party administrators who they don't really have. They're like, okay, you spent $1 billion this year, next year, let's say it's going to be $1 billion too. And a narrow network is a network of clinicians or health systems or hospitals that are in network with that corporation so that their employees can get care from them in an in-network stance by bypassing the actual big insurances. Some insurances have narrow networks as well, but corporations saying we want our own narrow networks, that's, I think, going to move the needle.
Yep, and that's doing a better job in a way, right?
Doing a better job should move the needle. It doesn't always happen.
It does eventually, is all I'm saying. Like, eventually it does. Like, it's way too slow.
Yeah.
As an investor, do we have time for eventually?
Go ahead. I'm sorry.
Yeah. As an investor, do we have time for eventually? Don't misunderstand me. I'm not suggesting that the system is optimal. I'm not defending it at all. I'm just saying that it's not, like, I think a lot of people look at big constructs and suddenly feel helpless. And, big constructs do come down. It was the only point I was making. And as an investor, I want to invest in the thing that is basically, taking alpha away from that system by being better.
Well, and that's a good point in some ways. And Jackleen, I want to say one thing. You can pick on Bill about using his European slang, like wonk. We don't say that in America, Bill. Like, so can you define that for us? What is a wonk? And
A nerd.
technical definition.
A nerd. Yeah.
Okay. I didn't know that was a nerd. Okay. So thank you for clarifying that for me. So framing this right, Bill, you're saying something that I entirely agree with in some ways. Doing things better is key. And years ago, I had an oncologist, never forget it. It was one of my whys. Why am I in healthcare? I was in the operating room with a senior oncologist at the time, which to me he was probably my age, right? Like, and I'm like, oh gosh, what has happened? He said to me, if we just created a situation where we manufactured a healthier patient, we just focused on that part, the manufacturing process, that would be where we would transform healthcare. And this was 34 years ago, 33, okay? Jackleen, you're doing it better, okay? I think the manufacturing process and cutting the noise of all of it, right? You mentioned like how a patient knows what to do, right? Using tools and resources and knowledge base that they can access today. That's great, okay? They're still confused because every doctor gets a body part, right? Everybody gets this, everybody gets that. And then you get discharged from the hospital and they go, all right, well, good luck, right? And there's a place where things start and stop and care gets delivered and things doing it better, okay? So I'm kind of framing it with Bill's thought in mind. Resilience doing it better, in my opinion, okay? For that patient that's discharged that doesn't know what to do, right? Tell me your take on how you've simplified that and what does that actually look like? Both for the hospitals, but mainly start with the patient and then maybe the hospitals and that framework, because that's like one of the unique things, I think, in my opinion.
So I spoke about us having three verticals: acute care, physical therapy, and then rural health initiative. So for the physical therapy is probably the easiest to answer that in the most simplest terms. So historically, if you wanted care at home from physical therapists, there's been a big push for home health, right? So you go through a home health agency. Home health agency was really, and let's go even more specific since we have a huge support system and footprint in the orthopedic space. So an orthopedic patient has a spine surgery or total hip or total knee. They are going to go home after, and it used to be that they would spend a few days in the hospital. These are now outpatient surgeries majority of the time. So you're going in, having that huge procedure done, and then you go home that afternoon. And then you can have a home health agency come see you. Well, home health agencies were really built for an episode of care, and that episode is really built on a nursing front. So nursing, yes, you're supposed to have PT, nursing, etc. in that episode. Well, a lot of these patients, especially now because total knees, for example, patient population is younger getting total knee replacements because knees are lasting longer. It's no longer a 10-year surgery. These are the amount of innovation that's happened in those types of surgeries. I mean, you're going to have that knee and you're going to have it 20 years, 25 years. And so we have a younger population getting these knees. Home health patients are supposed to be homebound. These are not homebound patients. There's a gap in care for those patients. And so for us, I was like, we just need to simplify providing physical therapy. I don't want my physical therapist to go in there and do a bunch of homebound structure and things that are really not. It's a waste of dollars and time. I want my PTs to go in there. I want them to focus as a physical therapist. I want them to be highly educated and trained on orthopedics because that's the patient population you're seeing. And so we just kind of threw out all of the rules of home health and we said, well, we're just going to do outpatient care. And if I'm just changing the setting of care, I'm still if you go into an outpatient PT clinic, you go in there, you're there for an hour, you're doing your PT session. I'm just changing the setting of care. I'm just bringing the PT to you. I'm changing nothing else. And so And so that's how we structure our outpatient PT at home program. So they're hospital-owned programs. It's physical therapy. We're dispatching just a PT to the home. And the first thing we say to the patients is, we're not a home health agency. We don't provide nursing care. We are a strictly physical therapy program, and we are an extension of the hospital. And we provide physical therapy in the home. You do not have to be homebound. We are an outpatient program. Instead of you coming to me, I am coming to you. And that's it. And that just makes it so much easier for these patients too. They don't have to be worried about, oh, if I drive to lunch and meet my friend, I'm no longer going to be able to get PT at home, but I really can't tolerate driving to a clinic 3-4 times a week or whatever the case. So that's as simple as it gets. So we just kind of like threw out all the rules and we were like, okay, what kind of care do we want to deliver and how do we make it easier for patients? And then we went back and read the rule book and made it fit in the rule book. And we did that with every vertical. Acute care came along because Medicare pushed for a hospital at home program during the pandemic, and so that has its own rules that Medicare has put together, but that's what we've always done. I just want to treat a patient. And in some rural markets, I just want to send the nurse to do an infusion in the home so that they don't have to sit in an ER to get an infusion at, guess what, 12 times the cost. And so let's just put the logistics together. We're a logistics company. We're a very fancy logistics company. Let's put the logistics together and then let's figure out in what payer structure and what contract structure can the health systems actually be reimbursed for these services. And don't tell me, oh, we're just going to penalize you less because the patient didn't come back to the hospital in 30 days, because that doesn't cover the cost for the hospital. So that's how we've always operated.
You're a key component of the manufacturing of the health of a healthier patient, right? Like if they don't get that care, they are potentially going to come back to the hospital. They also might not be able to walk as well, might not be able to, go through cardiac rehab and actually physically live longer and a healthier life, right? Which is what we talk about here all the time.
We didn't even touch comorbidities,
Exactly.
So
yeah, you can if you want. You can touch on it. It is relevant. Like you start to think about the things that are missed post-discharge are massive and can really determine a pathway for years of recovery, right? And PT, whatever, getting patients moving and keeping them moving and also making sure they're okay, even just to that basic level, they go home and they will have that. Right.
One thing the education system did really well is I think they've drilled in every discipline. The patient history, the patient story, you will get the most out of. Never mind their labs, never mind their special tests, their history. The patients, they know their body and their history is going to tell you a lot more than any test will ever tell you. And I think the system forgot that because we have different specialists and the patient's body is fragmented and care is delivered in a fragmented manner. When we go back and the patient, it's one body and it's one history of that body, and all of our systems, they're working together. Your musculoskeletal system is not working independent of your cardiac system. They're working together. And so comorbidities is a big deal. And so if I have an orthopedic knee patient, but they are diabetic, they have high blood pressure, they have cardiac issues, them not getting physical therapy and moving to get independent, it will affect their comorbidities, and vice versa. If they are not taking care of their cardiac issues and they're not taking their blood pressure medication, or if they're diabetic and they're not managing their insulin well, they are not going to get good function, and their knee's going to get worse because they're not moving around. And so we forget that as a health system. And I think back to patients having ownership over their own bodies and having ownership over and knowledge over how their own health system works. They can advocate for themselves better because they can understand the system a little bit more.
I would agree.
We have a ways to go. As you say, Todd, we can't boil the ocean, but there's a lot we can do in little pockets that might move the needle.
As we move the needle, we assemble it and we say, look at what we did, right? I mean, you think about history and knowledge base of that patient physiologically, they do know a lot, but then they have different doctors for different purposes, and they only point towards each other, whether it's a pulmonologist caring just about the lungs, heart disease, cardiologist, And that whole focus, or orthopedics and the knee you mentioned, it's like it all connects, and that whole vision of how the patient gets better, not worse, but better, is kind of the mindset. And using the power of information is a novel concept in healthcare, which I think you're doing well. So good for you.
There's another interesting overlaying trend that we see in lots of different areas of society, which is there's an oscillation that happens between centralizing stuff and decentralizing stuff. So like right now, people think of AI as something that happens in a remote data center via a web browser because it has to be centralized. And we're just seeing now a change where you've got edge AI where people are running their own models locally on their phones and on their own hardware because it's so expensive to do the centralized thing. And, doctors used to only do house calls, right? They didn't do much clinic. They did a lot of house calls, and now it went all into centralized. And now it looks like the edge management looks like it's a better model. And I'm just curious, do you see even more at-home technology, more at-home treatment? Is this a wave that you're on the crest of?
I love that you said that because we talk about it all the time. Like healthcare started with house calls. Doctors used to come to the house, and then hospitals were not built to treat everybody. Actually, in most areas, hospitals were built to treat the homeless or those who could not afford house calls. And then a shift in payment happened, in which case they realized, oh, we can make a lot more money if we centralize services. Now there is a need, of course, for hospitals, and there is a certain patient who has to be monitored. They need to be in the hospitals. And so I think decentralizing healthcare, building out the logistics, even a lot of decentralization, you still have a hub. And so if the hub is the hospital or the health system, and I think that's why our model works. When we first started, we didn't work with hospitals. We almost worked against them because we were just direct to consumer, and then realized why are we swimming upstream? Health systems exist, and and having a partnership with these health systems and then expanding their footprint is a way to make an impact on the population. So let's do that. And so you still need that hub. You still need that central escalation point or de-escalation point. But there's so many services that we provide in the home, like that could be provided in the home now, today, with technology. AI, yes. Even technology that's not AI, but you could do x-rays at home right now. You can deliver oxygen, you can do ultrasounds, you can debris wounds at home. There's just so much you can do at home. No, you cannot do an MRI in the patient's house. They don't have an MRI machine. They need to go somewhere. But for a lot of things you can.
That'll change.
AI,
it's going to definitely change.
Yeah, when they create an MRI machine that's this big, but efficiencies at scale, absolutely. 1/4 of American healthcare dollars goes to administrative work that can be automated with AI. So and when I say that, we're talking about $1 trillion. So $4 trillion plus. I think it went up this year, but it's a $4 trillion industry.
They're forecasting 5.7 in the U.S., which is just an astronomical number. And you're saying
we got
it like
smarter, we got more efficient, and it got more expensive.
Yeah, it does.
Yeah. And so, AI for sure on the technology front, I think it will decentralize a lot of the care because we can manage the logistics around delivering that care safely. We're also in a very litigious country, and so there is a lot of risk management involved in providing healthcare. And so I think the technology not only makes it possible to do it, but makes it possible to do it in a way that you can do it safely and efficiently, which this is now that, startups are a little bit looser when it comes to that. When you start working with health systems, it is the first question. It is risk management. It is, have you been sued and did you win? And so I think technology will help mitigate a lot of that as well.
When you were doing physical therapy, did you imagine yourself having to learn so much about cybersecurity in your career?
No.
Has she now built a platform that has a lot of data in it, right? Like it is pretty crazy.
That's one of those risk questions that I know your hospital IT departments are, especially since they've been so slack. You see so many hospitals have been shut down by cyber attacks. There was an interesting case in Romania recently, though, where the hospital fought back and actually destroyed the cyber attackers.
Really?
Yeah.
Here,
Don't mess with Eastern Europeans. they know a guy.
Yeah. Well, you think about like all the novel things that are happening, and what you just summarized is spot on. The patients are, all of that's going to kind of come along. What I think is, for us, it's the reduction in catching disease later and treating it later, as opposed, is going to really reduce the cost. And we're still trying to move the needle in catching that disease early. There's not a lot of money in selling drugs to fulfill a late stage disease. I mean, an early stage disease. So flipping it on its head is something we're trying to do in the diagnostic process, and how you get those done in the home to make sure you head off those diseases like comorbidities, just like you're talking about. It takes people and a positioning and being there, right? And being present in that process of care delivery. And that's how I see it, but
Yeah, no, I agree. And I mean, it takes patients advocating for themselves too. And we had talked about this. I know, Todd, you and I had talked about it too, like with resilient healthcare, especially on the physical therapy side. You build a relationship with these patients. You're in their home 2-3 times a week, and you're seeing them through their recovery, and you're understanding their lifestyle. And that is just so much, like it used to be when the TVs were new, everyone's like, oh, you could get into somebody's living room, and that was the new ad dollar because you wanted to be in someone's living room. And then it was the internet, and then it was Amazon, and now in healthcare we are actually in there, and we're learning their behavior. We understand their family dynamics. We're a trusted part of their family ecosystem around their healthcare delivery. And so we had talked about, and as we build this platform too, we're thinking more broadly. Initially, it was a lot of logistics, like we need to be able to manage this care. Therapists have to be credentialed by the hospital, and so do nurses, and we need to make sure that you're only seeing patients that are of that hospital system that you're credentialed by, and all that logistics. But now, especially with AI and building like native AI platform, we are thinking more broadly. Like we're interacting with patients on an almost daily, multiple times a week, and we have hundreds of new patients every month now. And so, and we have rich data and information about these patients, but we want the patients to be able to advocate for themselves. And so our AI agent's name is Benny. Benny was really built for the clinician. So Benny learns physician protocols, he learns that patient's history, he learns, he or she, whatever you want to call Betty, but the AI agent learns all of this, and it can answer questions from the clinician, and at point of care say, oh, this patient is well ahead of schedule as compared to all other patients of this doctor at this phase, or this patient's kind of lagging, or here is the protocol, or etc. So we built it in a way to be almost a digital twin, helpful, whatever you want, a fancy word you want to use it, but it is a helpful AI tool for the clinicians at point of care. Now we're thinking more broadly of, because patients are interacting and they are asking for things, or they are giving us information, or I had a knee replacement, but now my left knee hurts more and my right knee is my surgical knee, and I don't understand that. And so they will at some point start asking for diagnostic testing themselves. And if they also have access to these AI agents that are built on their records, then they can, and then you come to cybersecurity and there's that whole world there. But just at the face of it, I met this other founder who's started a company that I actually really love, and it's called Neela, and she said something to me. She said, we built it, and I am the demographic that we built it for, because, not me, but her, because I am the firstborn female, and usually it's the firstborn female that takes the responsibility or burden of caring for managing the healthcare issues of the family. And I have an older sister, we're a year apart. Thank God she is the older one, because she takes all that responsibility, which allows me to build this company. But she said she calls them the Marys. She's the Marys of the world. And Neela, their idea is using AI to help support the Marys of the world. So Mary can ask Neela, hey, can you tell me about my dad's lab work? Or can you tell me about, and oh my goodness, if I had something like that when my dad was going
Much
through
better.
his process, that was getting fed all of his records from every hospital that he went to. I mean, that would have made, and I still get PDFs of records that my family downloaded from Epic to ask me to explain to them what's happening. So anyways, to that said, I think there's a lot of AI products that
I
are
think
actually
probably all
taking
three of us are
place.
that proxy on our families
Yeah.
at
Yeah.
this point. Interesting.
Am I dying? What does this mean?
Yeah. What should I do? Right. And I think that that's a question that we get a lot because people don't know what to do. Like they just don't. They're learning. There's process, and Speaking about that, if you had advice, I'm carrying. My mom. Again, we talked about her already. She's going through a health journey. Every 83-year-old does at some point or another. And you know, the advice for the families to know what to do, I think, is a really key thing. People don't know. They don't know how to get the body part, doctor, clinician team together and go, what are we doing here? Right. And sometimes that's missed because it's all relevant to each part of the body. But any advice for the audience in that area? So it's because you're,
Be an advocate. I mean, be your own advocate for sure. Keep your medical records. Keep all of them. Eventually, there will be multiple companies that will allow you to put repositories in there of your medical records that can help you decipher rather than just going on WebMD and trying to figure it out on your own. But for now, be prepared for that because I think it's coming and I think it's already started. And I'm hoping to see in the next 6 months tools like the ones we're building, tools like the ones other companies are building will allow for you to be able to, and I know you were building something like that too to help with your mom, but it'll be around, I think that's pretty incredible. But being your own advocate and don't let them tell you no. Here's my own research. If you challenge, and it's coming from a clinician, sure, challenge me, and maybe you found something that I didn't, and let me review that, and maybe not.
Well, I want to
That's
add
a
a couple
doc.
of bits to that. There's a company I know called Claris, which has a really cool way of uploading your medical records and then gives you interpretation of them. There's a company called Smarter Blood. There's another startup that allows you just to upload blood work and gives you good opinions. And there's a really cool AI called Consensus, which is trained on peer-reviewed papers and not hearsay or science fiction. Because a lot of stuff in ChatGPT and Claude and these other platforms is polluted by science fiction and basically garbage. And so Consensus is just focused on peer-reviewed papers. And so what it does is if you give it a question, it looks up the peer-reviewed papers and then it gives you an AI summary of what they mean, which is a really good use of AI. Because it's not trying to be the source, it's just interpreting what the papers are saying in language that you and I can understand.
Yeah,
this
no, that's a very good point. I mean, our AI is trained on the protocols that we put in and the medical records that we're getting, and so because chat doesn't always, give you real data. But that said, yeah, I mean, it's really cool. I'm really excited to see how AI transforms healthcare in a good way over the next 6 months to a year. And I mean, we're service based, right? Like, yes, we're an MSO, we're a technology, but we make money by providing services to patients. We enable care, and so we don't want to tell you that your computer has a virus, but not fix the virus. So all of those types of systems, they are good for us because we want to be able to provide that service into their homes, or at least in managing care delivery to the patient, allowing the patients to know that they have these options and this is what it's going to cost them, as close as we can get to.
agreed. The technology
Absolutely.
is super exciting for us as well. Like we're seeing, we look at 500 companies, 500 companies a year, and the advancement today is faster than it was a year ago, and so on and so forth. And I just think there's a lot more information that would be diagnostic in the home, even down to testing your cortisol levels, your hormones, your Mammograms might be completely obsolete in very short period of time, right? So all sorts of exciting innovations. Speaking of those innovations, it's the road ahead. Like, right? What has to happen? I wouldn't call business. There's a lot of buzzwords around hospital at home and care in the home. The hospital at home, component is definitely something to touch on. But curious from your perspective, what has to happen in the next 5 years for that to become mainstream and the patients to get more and more care in the home? And what are your thoughts there?
So, hospital at home buzzword is usually used for acute care hospital at home, and it was tied to pandemic. It was tied to Medicare's waiver program. It went on a hiatus in September, came back in January, and now it's a 5-year program. What we do, yes, we stand up acute care home. Bulk of our business is really outpatient hospital at home is what we've called because they're outpatient service lines. I think you can touch a greater population that way, and we wanted to treat patients not in just the 2-3 day acute care phase of their life cycle, but actually holistically treat a patient. Patients, I think, are learning. It takes time. I mean, it's been a few years since the pandemic. It's still a growing program, and hospitals extending care into the home is almost every health system's top 5 initiatives. Every system we meet, we're asking, what are your initiatives, so that we can make sure we're one of them before we start talking to them. And always top five. And it's not just in the US. I mean, globally. I went to Dubai a few years ago. A lot of their initiatives were extending care into the home. So 2 things. One is the health systems are seeing that it is a need and it's a want by the population. To hone in on population wanting it, population has to know it exists. And there is still a lot of people who don't know that they can get a lot of these services in their homes. Wait, really? You can come to me? That is still a conversation being had. Now, we are seeing in a lot of hospital TV shows a call for hospital at home, or a extension into the community, into the home, caring for homeless patients on the street in some of these shows, saying, oh, we can do that at your house. We'll just discharge you and send someone to your house. And I think that, crazy as it sounds, Hollywood comes in pretty clutch when patients are trying to learn about what is available to them. And that, I've been seeing that a lot more. So that's been really exciting to see.
So guest spot on the pit.
Yeah, yes. Yeah, that's right. And yeah. Anybody know anybody at the pit?
We'll we'll talk about that on another. That definitely can happen.
I know someone who knows someone.
Yeah, exactly. So
East
go ahead.
Coast guys, they always got a guy.
I'm as far east as you get. I'm in Ireland.
So in that period, if all that which I think it's coming to fruition, right? We're seeing the traction, we're seeing that happen, and we're seeing the patients become more aware when you get, like when you're going home, what are the accessible services? How can that happen? Where do you think you'll have the greatest impact first? Will it be with the patient? Like, is that what it is? I think it will personally, but love your perspective of that.
I think it's the patient. I also think it's the clinicians and the physicians. Patients do trust their doctors. Some don't, but majority of them still do. The ones that don't are usually the loudest, and so there's a little misconception there, but patients usually do trust their doctors, especially a doctor you're allowing to cut you open. And so I think physicians getting on board with these kinds of programs, and a lot of our early work was educating doctors on this is efficient, this is safe, and there was, a lot of uneasiness. Oh, especially with the acute care patients. Oh, I don't know, they're here, they should be admitted to the hospital. That makes me nervous that they're going to go back home. And so educating doctors, and then doctors getting feedback from those patients. And I mean, patients are obviously, it's more convenient for them. They feel better. It's at home. And so I think it's both, Todd. I think it's the physician engagement around it, but it's also the patients learning about it. And once one patient experiences getting care at home, they tell everybody else in their network, oh, you don't need what? You just have them come to you. I had that happen. And so I think it'll come from those two. Health systems already see it. It's one of their initiatives. If you're a local, if there's more than one health system in that local community and one health system is able to see a patient where they are and another isn't, who do you think that patient's going to pick? Like, the patient's going to pick the health system that can come to them, that's going to make it more convenient for them, and who is transparent about their billing and pricing.
And also not just them, their families, right?
Yes, correct. And then, of course, and I think there are a few health systems. Baylor is one of them that has done a really good job of patient engagement on their technology, because they know that if the patient is engaging on their technology and their families are engaging on their technologies, that they will stay committed to that health system. And so getting engagement from patients and their families on the systems that we build and the platforms that we build, I think will be a huge driver for us.
I totally agree. You said something really notable. The doctors and understanding that it can be done differently, that creates better outcomes. I think that education and proof is in the pudding, right? Like they definitely see that. It's just hard to get them to stop and see that sometimes. So we like that thought process. There's a lot of change to happen, and you're part of that change. So it's been a great conversation, and really excited about that. Rapid fire. One misconception people still have about care in the home.
That it's not as safe as care in a building. But it is, and the outcomes are there, and the research is there now, and the research will continue to show so.
People are happier in the home, right?
Yeah, they heal faster at home.
The stress of going somewhere can sometimes outweigh the benefit. And
Oh, yeah.
that's a huge
That
thing.
and also the massive exposure to other pathogens.
Exactly.
And the food.
Yeah.
Cortisol level, the stress and anxiety of transportation. Anyway, so totally agree. One habit or ritual that keeps you grounded as a founder.
I have 5 kids. They keep me grounded.
Yeah.
I'll tell you. So my kids are in sail camp this week. There's no room for other habits. So my kids are in sail camp this week, and my 7-year-old, it's his first year doing it, and he was really scared to sail on his own yesterday. And I said, buddy, you like it? I know it's scary, but you do scary things so that you can get better at them. And he said, you can't tell me how to feel. You've never sailed a boat. And yeah, pretty grounded. Yeah, I don't know who gets you more grounded than that. I said, yeah, you're right, buddy. I have never sailed a
Precocious.
boat. I've done other scary stuff, but I've never sailed a boat.
We could fix that. That's a travesty,
Yeah.
Jacqueline. We haven't sailed.
That is that.
We can
that child
remedy that.
will-
That's a good.
Yeah.
Once
So
they're in
yeah,
college.
have kids. Run a company. Have kids. You'll stay grounded.
Yeah. Truth.
Good tip.
Truth. So finish this sentence. The future of healthcare delivery is,
CEOs that are moms. We just covered this.
well, they do see some simplification within complication. So, I think that's definitely relevant. And we always ask, the last question is, who should we have on this podcast next?
Your mom.
Done. She's she's definitely feeling good enough to complain about.
And the
I would.
person after Todd's mom?
Yeah.
I would say Jim Kendrick would be a good one. Jim's on my board, Jim, but Jim has been instrumental in moving the needle in rural healthcare, and he is a true believer of pushing care into patients' homes in the communities, especially those communities who don't have a lot of healthcare infrastructure and do have medical deserts. So I think Jim would be really good for this podcast.
I think talking about, we could have a whole topic, a whole separate podcast on medical deserts, because there's a tremendous number of them in the U.S. and we try to go do philanthropy all over the world, right? But we have it right here, and then I know Bill sees it all over the world as well. So that is, and Jim's a great suggestion. He's, definitely would be a good participant. Jackleen, first of all, thanks for joining. Tell us where we can follow you or Resilient. I know how to get in touch with you, but tell everybody else. And we'll also put this in our show notes as well. It's available.
Resilient has an Instagram now, and I think it's Resilient H. I'm checking. Our staff has really been working hard on that. So follow us. Yeah, Resilient on Instagram. Our website is resilienthc.com. Lots of information there, and you can get in contact with us that way.
Awesome. And you're going to have a bunch of mom founders calling you and saying, how do we juggle all this? Like, anyway, I think it's been a
Love
great
it.
conversation. And if healthcare is going to become more effective, it's got to get closer to the patient. Conversations like this is where it's at. Like, we could talk about the next greatest therapeutic, we could talk about the next greatest thing, but if you're not centered around the patient, we're not really shaping healthcare the way I see the change needing to happen. So we're very thankful for you coming on the show, and really it was an enjoyable conversation as always.
Thanks, Todd, and it was so nice to meet you, Bill.
Very much my pleasure to meet you, Jackleen. Thank you so much for everything you're doing, as it's important.
Yep.
Thank
And
you. Thank you,
next
Jackson.
time on Killer Cure, we'll try to get Jim and my mom apparently, and we'll keep you posted on who's our next guest. So thanks for joining us, Jackleen.
Thank you, Todd. Thanks, Bill.
Thanks.